Thank you so much for the introduction and the opportunity for Will and I to talk about frailty. So frailty is something that I think Will and I think a lot about. In geriatrics, it's been a really hot topic for the past, I would say, a decade and a half or so. It's been a really important emerging topic in surgery for the past half a decade. But I think the science of this is just starting to filter out to other medical subspecialties. So we're really glad to have this opportunity to share with you about what we know about frailty. So these are the objectives. We'll talk a little bit about the definitions and the clinical presentations of frailty in older adults. We'll describe frailty in the World Trade Center general responders. This is not intended to be a research-heavy talk, but we'll touch upon that, which is a really important area that we're exploring and studying. And then we'll end with a discussion on the clinical management of frailty in older adults. I'm going to start with a clinical case. This was my grandfather. It was a picture of him taken when he was 94 years old. He lived in Taiwan at the time. Very vibrant, very physically active, independent person, lived on his own. He's someone who would, on a daily basis, walk in a park for several miles. He has some medical history, chronic diseases that were all very well controlled. A few years back, he was found to be unconscious and in his apartment, taken to the hospital. Turned out that he had a subdural hematoma. Neurosurgeon was consulted. They proceeded with a craniotomy, drained the subdural hematoma. And amazingly, my grandfather had a good recovery. He almost returned to his baseline physical function. He had some weight loss, some, I would say, frequent fatigue after the surgery, and some generalized weakness, and had a few falls. About a year after this initial incident, he was again found to be, unconscious in his apartment, taken to the hospital, and again had a second subdural hematoma. So craniotomy was done again, but this time around he had very poor recovery, had lots of complications after surgery, and his functional status remained quite poor and was unable to ambulate. He looked frail or cachectic with lots of muscle atrophy to my relatives in Taiwan. And for those reasons, he was transferred to a nursing home for care. And that was him in the nursing home, when we visited him a few years back. He, had an NG2 place, and because he didn't want it, he frequently will pull that out, which would lead to the use of physical restraints. He had frequent delirium, agitations that require pharmacologic sedation. He developed pressure ulcers and had many hospitalizations for a number of reasons listed here. For his last hospitalization, he was found to have multi-organ failure. He was in septic shock from pneumonia and bacteremia. He was hypoxic due to a pneumothorax and the pneumonia, and he had renal failure with no urine output. Medical management remained fairly aggressive. He got IV pressors, he even got albumin. The medical team offered a chest tube, which was declined by my family at the time. And they offered dialysis, which was consented for. He passed away in the hospital before any of these more aggressive interventions were actually done. So whenever I think about my grandfather, I think about these missed opportunities for geriatrics and palliative care and in-hospice care. I asked actually my relatives whether alternatives to physical restraints and tube feeding, sedations were considered and were implemented to some extent. I asked them how well palliative and hospice medicine focused goals of care discussion actually took place. And I frequently ask myself whether frailty could have been used as a way to help guide his management, especially towards the end of his life. So we're going to talk about frailty. If I ask if this is a live, in the same physical space kind of presentation, and if I ask all of you to describe frailty, I would not be surprised if this is a list of characteristics that you all come up with, right? So frailty is oftentimes associated With someone who's older, weight loss, fatigue, physical weakness, it's often described, those who are frail are oftentimes described to have disability and dependency, decline in multiple physiological systems. They're more likely to be susceptible to complications from treatment. Recovery from interventions tend to be delayed or incomplete. They're more vulnerable, and the mortality is higher, right? So these are some of the frequently used descriptors, I would say, of frailty. The question is, how do you take all these characteristics and meld them into a coherent definition? So one of the first attempts to do so took place back in 2004 at a conference hosted by the American Geriatric Society and the NIA. A group of experts convened, and at the conclusion of the conference, they have come to define frailty as a distinct clinical syndrome that's characterized by multi-system physiological decline with increased vulnerability to stressors and adverse clinical outcomes. Still a mouthful, but this is a definition that they came up with, and we thought that specifically for those who are frail, sarcopenia, i.e., a decrease in muscle mass and strength, decreased physical activity and exercise tolerance, weight loss and poor nutrition are key components or drivers of frailty syndrome. So many research groups and investigators have worked on operationalizing a definition for frailty. There are many of them out there. I'm going to cover just two of them. The two major, I would say, groups or definitions of frailty syndrome. The first of which, and I think many of you may have heard, is called the physical frailty phenotype, also called the free definition of frailty. This is probably, I would say, the most tested and validated definition of frailty that you can find in the literature. Dr. Free conceived frailty as a distinct phenotype, and that this phenotype can be characterized by 5 clinical features that are listed here. So unintentional weight loss, weakness as measured by grip strength in the hands, physical exhaustion, slow walking speed as measured by a walking speed test, and low physical activity. Someone who has 3 to 5 of these clinical features is thought to be frail. Someone who has 1 to 2 of these features is thought to be pre-frail. And pre-frailty is an average stage for frailty. The free definition is also called the Hopkins Frailty Assessment Calculator. The reason being that this was developed initially at Johns Hopkins. And I provide some links throughout the talk for in case you're interested and you want to look into these tools. So the free phenotype, as I mentioned, is frequently, it's very well validated and tested in many populations. And Will and I, among many of the investigators here at Sinai, are testing and learning about frailty, physical frailty assessment in the World Trade Center general responding population. And Will may touch upon that in a little bit. Central to the idea of the free frailty phenotype is what's called the cycle of frailty. So if you look at these gray ovals here, these represent the 5 clinical features of frailty phenotype. The idea is that each one of these features or oval could be entry point to the frailty cycle, and one could beget another. And then central to this frailty cycle are decreased energy expenditure, decreased metabolic rate, and sarcopenia. This is the second definition that I want to cover. It's also very well validated. There are hundreds and hundreds of studies that have looked at this. And it's called the Rockwood definition of frailty. And Ken Rockwood defines frailty as a deficit accumulation. And what does that mean? Well, frailty in this case is thought to be an average state that's caused by the age-associated accumulation of deficits. So in some ways, it's a reflection of multimorbid state, but it's really more than that, right? So the vulnerability that you see in frailty is thought to be due to this aggregation of related or unrelated abnormal health conditions or aging-associated conditions. One could tabulate the risk for frailty by calculating what's called a frailty index. And this could be done by identifying such deficits that are identified through a routine comprehensive geriatric assessment, or CGA. And what that is a very, very comprehensive and sometimes long evaluation in which medical psychosocial risk factors and needs of an older adult is actually assessed. So that's a CGA. So these are some of the parameters that are covered by CGA as shown on the left. And you can see that in the frailty index model, characteristics are important. The free phenotype, right, the functional components, the strength, mobility are also included. But then beyond that, cognition is considered, functional status, right, the social environment, and the use of medication, polypharmacy. That's part of the assessment as well. There are many different types of frailty indices out there, many of which have been validated in large cohorts. But I want to show you an example of what this could look like in a clinical setting. So this is taken from the Beth Israel Deaconess online frailty index calculator. And you can see, and I think I cut off parts of it. So there are actually more variables or potential deficits are assessed. But the way this works is that you can check off a deficit that's present for a patient that you're assessing. You then take the ratio of these affirmative deficits over the total number of deficits that are assessed. The ratio will give a score, a frailty index score. And in this case, the score came out to be 0.256. Generally, a score that's greater than 0.25 is considered to fall within the frailty range. I took this figure from a recent publication from Jeremy Walston, who is really one of the pioneers in frailty studies. And it really illustrates and contrasts the differences between the two definitions. On the left, we have the physical frailty, the free frailty phenotype, which in this case shows that the phenotype, which is here in the center, can manifest in different clinical presentations, right? The 5 clinical features. So there's this outward projection of these clinical presentations. In contrast with the frailty index, which is shown on the right, it's a reverse process. It is this accumulation of various deficits, whether it's medical, functional, cognitive, that can contribute to this increased risk of vulnerability that you see for older adults. In addition to these two definitions, a number of brief screening or assessment tools for frailty have been developed and validated. The Frail scale is one of them. So John Morley and his team created this scale. In some ways, this is a very much a parallel of the free phenotype. These are questionnaire-based questions that look for fatigue, ambulation, weight loss, for example. It's also on a scale of 5, with 3 to 5 being frail and 1 to 2 being pre-frail. We're also assessing frailty with Frail scale in the World Trade Center study, healthy aging study that we'll talk about in a little bit. There are many frailty screening tools that are developed specifically for a clinical setting. So I mentioned, when I first started the presentation, that the surgeons are really interested in frailty. And part of the reason is that, the traditional way of assessing when we do our pulmonary preoperative medical assessment, I think the surgeons have found that it's not these, cardiac risk predictor stratification tools are not always reliable, so they have turned to frailty as a way of perhaps coming up or enhancing the existing frailty assessment, surgical risk stratification tools that are already in clinical use. So the Essential Frailty Toolset is one of those examples. This was designed specifically for aortic valve replacement surgeries. It has a functional assessment component involving a chair rise test, a brief cognitive assessment, and then 2 lab-based values to look for anemia and nutritional status. and was found that patients who are about to undergo aortic valve surgery replacement who are frail are more likely to have higher mortality. I wanted, this is, so a few years ago when I was attending on the geriatric consult service, I actually came across a patient who was about to undergo TAVR, who had the EFT assessment done and documented in Epic, which I was really impressed because I feel like, at least in some practitioners, they're really trying to advance the utility, the application of frailty in the surgical context. I think this is the last frailty screening tool I want to talk about. It's called the Risk Analysis Index, or RAI. It's a 14-item pre-survey that's used to screen frailty for elective surgeries. It was developed at the VA in Pittsburgh. This is probably the most thoroughly validated measure of surgical frailty that's out there. It's based on the frailty index model. So it assesses for social, functional, nutritional, physical and cognitive domains with 14-item questions. And it's meant to strike this balance between the ease of administration, and this could be done in 2 minutes or less, and its predictive value, such as mortality, in order to risk stratify patients who are at higher risk for surgical complications. This is what it looks like. I know the font's a bit small for you to see the specific questions, but it again is a simple survey tool. The cutoff that's been established for RAI is 37. So someone with an RAI score of 37 or higher is thought to be frail. And those who are thought to be frail are more likely to for example, have higher mortality after surgery, longer ICU stay, among others. I'm going to end this section with a few slides on epidemiology. So because of the validation and operationalization of the frailty definitions, we now have a lot of data on the epidemiology of frailty in older adults. So cardiovascular health study, or CHS, was one of the first studies that was used for this purpose. It was found that in this cohort, the 4-year incidence and prevalence of frailty was about 7%. Frailty was found to be associated with older age, the female sex, certain race and ethnicity, as well as lower education attainment and lower income. It also been found that baseline frailty status is predictive of adverse outcomes. Some of these adverse outcomes are listed here on the left, such as falls, worsening activities of daily living, hospitalization, hospital readmission, and mortality. Women's Health and Aging Study is another longitudinal study in community dwelling older women in the Baltimore City area, and similar findings were discovered. And lastly, preoperative frailty predicts adverse surgical outcomes. And I mentioned that earlier. So this is taken from a recent study using RAI to assess frailty. And you can see that those who are frail, i.e. 37 or higher with the RAI score, are more likely, or I should say have increased risk for post-surgical mortality, hospital readmission, longer length of stay, and longer ICU length of stay. I would just add before I hand off to Will that I've only presented a really, really small number of articles or papers on this topic, but really these findings have been duplicated in many, many cohorts, many studies nationally and internationally. So with that, I'll hand off to Will to talk about frailty in WTC general responders.
Thank you very much, Fred. I am going to present a few slides on the work that we have been doing on using the data from the World Trade Center general responder cohort here at Mount Sinai, and which includes both the use of data already collected and also some newly collected data as well. So as Fred has actually talked about, there are quite a few different ways of assessing frailty in a population. And one of the strengths of the general responder population database here is that there has been data collected throughout the years, thanks to the work of the One Trade Center Health Program, ever since the program established in 2002. So that allows us for the opportunity to examine health status of World Trade Center general responders over time. And as they age, we can actually examine their frailty status using the data. We have been introduced to this data by Roberto, who's been really expert in and has been involved in this field for many years. And we have actually our first sort of pilot project funded by NIOSH that actually used this data to establish frailty prevalence using the data. And we have actually do this through the strategy of establishing a frailty index using a deficit accumulation model. Now, we know that the deficit accumulation model has its strengths, being that it actually uses data already collected and is multifaceted, but also is limitations as well. So how well does it correlate with some of the data that Fred has presented on the frailty phenotype? We don't necessarily know that well in terms of particularly in this population. So one of the key reasons for doing this is actually to correlate the deficit accumulation model frailty index with the frailty phenotype, and we'll present a little bit of data that pilot data that we have that has done a little bit of correlation as well. So, using the deficit accumulation frailty index, so we have actually used a 30 item clinical frailty 30 item data to establish the clinical frailty index. So we use the health monitoring data that is collected from mental health questionnaires and physical examination that is actually from 2012 to 2017. The deficits that we have included in those from those data were persistent fatigue, unexpected weight loss, medication use, self-reports of difficulty climbing stairs, problems with short-term memory, difficulty concentrating, and other deficits that is related to chronic diseases, specifically also World Trade Center certified conditions as well. So we have actually looked at the information here and actually look at what actually would be considered in terms of frail, and we have actually thought that actually as we're looking at correlating with other studies that have used similar approaches for frailty index using cutoffs, we have actually close to a third of the cohort actually meeting criteria for frailty. And we have looked at in terms of what sort of factors are associated with being frail. And those were included here in terms of age. So that is not a surprising factor that's associated with frailty as somebody gets older. 9/11 exposure severity, and also occupation as well, particularly higher in certain occupation that has more physical activity, such as construction workers. Next slide, please. So we do want to look at the frailty trajectories in World Trade Center general responder. Once we have actually established sort of cross-sectional sort of frailty prevalence, we have actually started to look at in terms of how that progresses over time. So because the World Trade Center Health Program has data over time that we are able to actually establish using the frailty indexes established and actually looked at the trajectories over time. So we applied the latent cluster mix model to model the patterns of change of frailty in the World Trade Center cohort using the clinical frailty estimates over time. And we have used the longitudinal data that is from the monitoring visits from 2004 to 2020. There's a total number of individuals that were included with 17,000 and change. And we have looked at what trajectories came out of the analysis for looking at latent traits. And we found that three distinct trajectories were shown here that has an increase in frailty score over age, and that's not an unexpected thing. But there are different trajectories based on the red group would be actually when they have low frailty score or frailty index in the beginning, and actually also has a very slow and gradual increase over time. That's the red group here on the graph. The green group actually has a low frailty, relatively low frailty in the beginning at younger ages, but increased relatively drastically over time. And then the blue group had the highest frailty score also at baseline, and also actually that have moderately increased over time as well. And these frailty trajectories, what are the factors that actually drive these? They are associated with World Trade Center exposure. They are associated with sex, education, income, and occupation as well. Next slide, please. So in one of the, as we want to look at one of the factors that actually is associated with frailty and potentially could be altered in perhaps actually potentially changing trajectory of frailty trajectory is actually in potentially optimizing medication use. So we have actually looked at medication use pattern in World Trade Center general responders and look at actually medications, how many medications they are taking, the type of medications they're taking, and some of the factors associated with associated with actually increased number of medications being used. So we have looked at, so in terms of defining polypharmacy, and that's a term that has been used to describe multiple use medication. It has various definitions in literature. One of the accepted definitions has been 5 or more medications, and that's not a huge number, but you'd be surprised at potential interactions across just 5 medications, and then there is actually also hyper polypharmacy that is actually in the 10+ range, so 10 or more medications. And also we looked at what is called FRID use. FRIDs are falls related fall risk in increasing medications. So these are medications that are associated with increasing risk for causing falls. There's those medications include benzodiazepines, they are first generation antihistamines. These are medications that have anticholinergic properties that are for older adults, for aging older adults, that actually does confer additional risk. Skeletal muscle relaxants, tricyclic antidepressants, and some long-acting hypoglycemics as well. So in terms of the pattern of use of medications, we do see that more than half of the World Trade Center responders actually take 5 or more medications. And around a fifth of them take 10 or more medications. That's a huge number. And this is, and do remember that, polypharmacy is increased with age. So this is actually a relatively younger population when we look at polypharmacy patterns or medication use patterns as well. And for fall risk increasing drugs, there are about 8% of people actually taking some of these medications, which may actually be potential targets for thinking about modifications for medication use. So we also looked at factors that are associated with polypharmacy. So we found that women were more likely to be taking more medications. We didn't find particular association with race or ethnicity. Not a huge also association with World Trade Center exposure. There is actually a association with obesity, and a number of World Trade Center certified conditions would be associated with increased use of medications. And lastly, in terms of for frailty index, deficit count for World Trade Center frailty index, that there is an association with deficit count together with increasing medication use. Next slide, please. So we have actually this is actually part of the prospective data collection that we have actually done in the pilot, and we're currently actually ongoing data collection in the current UO1 study that actually will continue for another 2.5 years. So we are actually looking for folks to refer to us, folks to World Trade Center general responders for collection of this data as well. But this is actually some of the pilot data that we have looked at. The main thrust of this approach is first actually to correlate using the phenotype score, so for measuring frailty and correlating that with the frailty index that we have used in the previous large cohort study. So we have actually developed and tested some protocols to assess frailty. We use frail scale, we use the physical frailty phenotype, and also other age-related indicators of physical and cognitive function falls. We have actually collected this data in a pilot cohort of World Trade Center general responders of 100 or so and change of individuals. And we have actually examined what the association is with the World Trade Center certification, World Trade Center in terms of conditions, and also in terms of related to falls and fall risk and fall efficacy scale as well. So we have found a couple of things. So this is relatively small numbers. We do find that that there is actually obesity being one of the factors that is actually substantially related to frailty, and certain World Trade Center conditions having World Trade Center certified conditions associated with frailty, and also in terms of having World Trade Center certified mental health conditions associated with frailty. And I would actually also say that the pilot data that we have collected is relatively small numbers. We are actually still collecting more data in order to allow us to correlate the different frailty measurements to a certain level of confidence that we can actually do that. And also, while we are actually collecting this data, we are looking at different ways that we can actually modify frailty trajectory through health interventions as well. So I'm going to turn it back over to Fred to talk a little bit about what do we do when we actually are faced with individuals who are at risk for frailty or fail.
Thanks, Will. I just realized that we got so excited in the moment to be able to present to the group that we have so many slides. So I'm gonna fly through the next section rather quickly so that we can have a few minutes to hopefully answer some questions. But I'm gonna focus on how we could provide care for older adults who are frail. So the clinical care of frail older adults have, I would say, many challenges. Frailty occurs in a broad spectrum, right? So that makes the screening diagnosis sometimes difficult. Patients who are very frail especially tend to have high medical psychosocial complexity. As you could see by now, there's a lack of a gold standard definition for frailty. There's also a lack of definitive therapy. And there's no consensus treatment guideline that's universally accepted. So these are some of the challenges that I think makes the treatment, the care of frailty a bit more difficult. But that being said, there's a framework that we could use to think about frailty management. So if this arrow indicates increasing frailty, screening can always be done early, right? To try to detect and diagnose and spot those who may be frail. Geriatric type of care, including goals of care discussion, symptom management should always be part of that conversation. Exercise interventions and patient-centered interdisciplinary care models have really been shown to be helpful in either reducing some of these characteristics of frailty or adverse outcomes associated with frailty. And this should be part of the care process. And then in older adults who are very frail, severely frail, palliation and hospice care are entirely appropriate and should be part of their care. So I'm going to talk a little bit about exercise interventions. You would recall this from earlier, right? So the gray ovals are different clinical features of frailty in the phenotypic definition of frailty. Well, these characteristics can all be reduced or mitigated to some extent through exercise interventions. And that's been shown over and over in the literature with both aerobic and progressive resistance training, or PRT interventions. So I'm just going to show, I think, one study, one of the seminal studies on PRT. This was done by Chrissy Liu and Nancy Latham in Boston, and they looked at whether physical outcomes in older adults could be impacted by PRT. 121 randomized controlled trials were included in this meta-analyses. There are different types of interventions that were done, but most of them were done two to three times per week for about 3-month period. The intensity tend to be favoring on the higher side for PRT. The modalities for exercise were different. Some use machines, some use free weights, some use elastic bands. But the takeaway from this meta-analysis was that PRT was able to safely improve muscle strength, gait speed, time that's required to get out of the chair, which is a standard geriatric assessment for physical ability, as well as some of the other self-reported function measures. I have 2 slides about frailty and exercise intervention. So when I think about frail older adults, those who are most frail, I think about those who are institutionalized or those who are homebound. So this is one of those classic study in exercise intervention in nursing home patients. In this specific study, high intensity PRT was done in the lower extremities over a span of 10 weeks, 3 sessions per week. And 2 to 3 sessions per week is fairly standard for these type of exercise intervention studies. It was found that in nursing home patients averaging 87 years old, with the intervention, they had an improvement in muscle strength and gait velocity. And this is a separate study done by Tom Gill at Yale, looking at exercise interventions in patients who are homebound. So the intervention was a 6-month home-based PT program that was coupled with PRT using elastic bands. And this intervention was found to reduce the functional decline over time in older adults who are homebound. So I think there's a lot of rationale to do an exercise prescription for older adults who are frail. I mentioned some of the reasons already that are listed on the slide, but I would say that despite what we know, there's really no consensus treatment guidelines that are being widely used in terms of prescribing exercise in this population. In lieu of that, Roger Fielding and Chrissy have suggested that the U.S. Department of Health and Human Services physical activity guidelines may be used as a guide. And as we all know, this is a program that calls for about 150 minutes or more a week of moderate intensity aerobic exercise that's coupled with resistance training involving major muscle groups on some days of the week. I know that's easier said than done, right? Because I mentioned earlier that frailty in older adults exists in a large spectrum. So clearly not everyone can adhere to that recommendation. So I think, there are other things that we must consider so that we can tailor the intervention that we recommend to the patient more, I guess, appropriately. So parameters that should be considered would include, duration, intensity, frequency, and modality of exercise. So, I think exercise machines tend to be user-friendly and could be used by many older adults. That being said, they're not always available, right? They're not easily available at home. So there's the inconvenience factor. So, elastic bands may be a really good substitute. And there are exercise involving all major groups using elastic bands that can be done in home setting. So that's what I mean by, considering these different parameters. There are different ways of identifying a modality, a way to prescribe exercise that I think can best suit the needs and the resources available to the patient. I think we all know that structured exercise training and supervised training can really help with adherence. I think the data for that is, more than sufficient. But I think as a provider or providers, we ought to figure out how to get these programs, how to present these programs to our patients, how to link up our patients to these resources. And that there's a lot of group exercise programs in the community, in adult daycare centers, senior centers. So the question really is, how do we pinpoint these resources and link them up with our patients who we are caring for? And that's where, having an interdisciplinary team, having a social worker on staff who's well aware of these resources could be helpful. Supervised training is helpful, as I mentioned. So, involving caregivers as part of the exercise regimen could be helpful. Getting therapists to go to the patient's home for home PTOT, that could be helpful as well. So there are things of this nature that I think we should think about when it comes to making recommendations for exercise interventions in older adults who are frail. I added this last slide on exercise really to show where the knowledge is at the moment. There's a number of clinical trials being done looking at multi-component exercise interventions in frail older adults, this being one of the earliest ones. And I think it's a good illustration of what I think exercise interventions would look like in the future. So it's multi-component. There's always some combinations of PRT and aerobic exercise. There's a lot of proprioception, stretching kind of exercise that's incorporated into modality as well. And that's shown here. In this specific program, elastic bands were used, stair climbing and walking were intended for aerobic training. And the schedule is shown here. You can see that for the PRT, right, the degree of intensity is increased over time. But just keeping in mind, because more papers will come out in the coming years about these specifics, of the interventions themselves and their potential impact and outcomes. I'm going to fly through the next few slides. These are focused on patient-centered interdisciplinary care models. So this is a model that's frequently used in geriatrics. And it's been shown for decades now, this type of intervention could be helpful in reducing some of these adverse outcomes that's associated with frailty. So for those of you who may not be as familiar with this type of model, I think this slide sort of captures the essence of it. So what this modeling involves is having a team of interdisciplinary providers, including physicians, nurses, nursing staff, social workers, therapists, nutritionists, among others. And the idea is that a geriatric-focused assessment addressing medical, psychosocial risk factors and needs in those domains are part of the assessment process. And then as a team, right, the team synthesizes that information and come up with treatment plans. And the objective interventions are many, and I listed them here on the left. And they could be patient-centered treatment goals and care plans. They could be setting goals of care. Frequently, that would involve, for example, improving or maintaining physical and psychological function, reducing hospitalization is a frequent goal as well. So there's a number of those that are listed here on the right that we often talk about in this care setting. This kind of intervention can be delivered both in an inpatient, outpatient setting. Some of those are listed here. In the introduction to MACE was mentioned, so that stands for Mobile ACE service, and that's one of such interventions that's been shown to be helpful in reducing adverse outcomes in older adults. The classic example is the ACE unit, acute care for the elders. This is a type of geographical physical setting within a hospital unit where the environment is prepared. The hallways are uncluttered. There are frequently handrails on the walls to encourage the patient to ambulate, right? Early ambulation hospital setting. There are frequently large clocks on the wall to help with orientation. Many of the interventions have protocols that focus on, independence or preservation of function. And this type of intervention has been shown to be able to improve one's ability to perform daily functions, as well as decrease discharge to an institution after hospitalization. I just want to quickly talk about this. It's a program looking at how CGA could impact the care of older adults. It's meta-analyses of 28 controlled trials, one of the seminal studies in this area. And the study looked at programs that are both in the inpatient setting, consultative service, CGA done in the home setting, care transition model, and outpatient clinics. And the gist of this the study was that many of these models were helpful in helping to reduce mortality, one's ability to remain at home for a longer period of time, reducing hospital admissions, as well as preserving physical and cognitive function. So I think, patient-centered team models really are helpful. And I think being able to incorporate this kind of intervention when feasible could be beneficial to our older, frail patients. I have a few slides just to touch upon some of the other important aspects of care for frailty. Screening has been mentioned. And the reason why I think that's important is because frailty could be missed. I think in my grandfather's case, he probably had some signs of frailty that just was never picked up. So early screening of frailty probably could have been helpful in identifying that earlier, and perhaps using that as a way to bring resources that he would have needed to help him age successfully at home. Many screening tools are available. We talked about this already. And currently, Will and I and our team is looking at assessing frailty with all three of these tools in the general respondent population in different capacities. I'm going back to surgery again because I feel like in terms of all the specialties, surgical or medical specialties that are involved in the care of older adults, I think the surgeons have really pushed this forward, incorporating frailty assessment into their practice. So there's an idea called the surgical pause that was that Dan Hall from Pittsburgh is really disseminating. And the idea is that before surgery, do a frailty screening. For older adults who are identified to be frail, the surgery should be paused so that the patient could be referred to an interdisciplinary team of specialists to do risk stratification. For patients who are very, very frail, a referral to palliative medicine for consultation on goals of care could be helpful to align the patient's values and goals. For patients who need some tinkering, right, to help them optimize for surgery, perhaps preoperative exercise or rehabilitation could be introduced in that capacity to get the patient more ready, right, so that they can undergo surgery and hopefully have fewer adverse outcomes. Symptom management is key. So weight loss is common. So, and we do this all the time in geriatrics, right? If a patient has, weight loss, we could introduce interventions such as liberalizing diet, varying the texture and flavor of foods, among others, to sort of encourage the appetite to increase oral intake. And then for physical exhaustion, there are things that could be done just by altering the environment that could really significantly reduce energy expenditures, and that could be incorporated as well. And lastly, for older adults who have severe frailty, as I mentioned, palliation is appropriate, and that should be introduced. And palliative care really captures the essence of CGA and everything we talked about so far, and that's summarized here. So going back to my grandfather, right? I think in his case, before the subbureau the first one has occurred, frailty screening, some of these things that we talked about should have been part of his care. As he had, increasingly more medical and surgical, issues, limitations, and challenges, other effective means of intervention should have been incorporated. So in summary, frailty is a geriatric syndrome that identifies the most vulnerable subset of older adults. It is common in general responders. Exercise intervention, team-based care could be helpful in their management and should be incorporated. I think clinicians should always be cognizant of frailty in older adults and incorporate appropriate screening and other measures into their care. I just want to acknowledge some of the current team members for the World Trade Center Successful Aging Study who are listed here. Also want to acknowledge GRDC and many of the World Trade Center Health Program stakeholders, the leadership for supporting the study. And our study is only possible because we have an advisory board, the members of which are listed here to really help us, guide us with the study implementation. So with that, I will end our presentation. Again, putting another plug about our study. If you have patients who's 50 years or older who speaks English, who seek monitoring treatment care at the Mount Sinai site, please redirect to them should they be interested in learning more about our study. So thank you so much.